Good morning again. And the second topic which was given to me is how to ventilate ARDS. So again, I'm from Dubai and working as a vice chairman of Department of Anesthesia and ICU in Al Jara Hospital. Before ventilating ARDS, let us see what are the complications due to ventilations that happens. So various types of injury due to our ventilator and ventilation mode or our settings that occurs, they are barotrauma, biotrauma, atelectatrauma, volume trauma. So what are these trauma? They are all traumas. Okay, we'll discuss in due course of time. Ventilator associated pneumonia, oxygen-related injuries like free radicals. They say like in head injury, hyperoxia is bad. So tracheal issues and mechanical damage, tracheobronchial, tracheomalacia to injuries. So these are the complications. So to prevent all this complication, we apply ventilation bundles. Start from head-up position to oral chlorhexidine mouthwash. Some people, they do selective decontamination of digestive tract. We give them acid prophylaxis. We give them DVT prophylaxis. So ventilation bundles we follow, but still it happens. Now, have you ever thought when the patients get ventilated, what they exactly feel? They feel pain. The control of pain during ventilation is very important because the plastic in your throat. Do you remember going to dental doctors? He puts that wooden, scalpel-like thing. You start feeling puking and it's painful, right? If something goes into the most sensitive structure of the body called larynx, they do feel pain. And when we ventilate, we take care of sedation, not pain, most of the time. So, how to ventilate? This is what happens when you attend a lecture or conference. They give you 10 more equations, 5 more modes, lots of confusions. You remember nothing. You come out from a ventilation lecture having more confusions, more equations, and some vaguely looking new modes. My ventilation lecture is completely out of all this. It doesn't have any equations. What I am saying is there are only 2 types of lung exists in this world. One is injured type of lung, the other is obstructive type of lung. So if there are 2 kinds of lung that exist, then we need only 2 types of ventilation. Simple, okay? Not knowing how to ventilate them can produce ultimately one type. You can injure the lung, right? So if you ask me that if the patient is of head injury, he doesn't have any lung problem, how do I ventilate? The basic principle in my lecture is if the patient is not having asthma or COPD or obstructive type of lung, you ventilate them at the other category, injured type. Alright? This is lung injury. Now, if you see clearly, 1/3 of lung has been gone by consolidation. They are not available for any kind of ventilation. Tons of modes available. I use all the modes all the time. But when the patient needs a tube and you are in a hurry to start with, please do assist control with volume or basically volume control mode. In this mode, why I am telling you, you will have a fair idea how is the lung. Once you estimate the lung, you can go for any mode. Alright? So we discussed there are only 2 kinds of lung. And all these ventilators with many knobs, we can divide into 4 parts. Basically, there are 4 knobs. If you can understand which knob is for what, then things will be simplified, right? So again, we have 2 lungs. One is injured, one is for obstructive or COPD or asthma lung. This is a injured Now, so what do we set in the ventilator? The first and foremost, you calculate the ideal body weight or predicted body weight of patient. A patient might be 250 kg, but his height is 5 foot 10 inches. His tidal volume remains the same. Nothing to do with body weight. The tidal volume of the patient is related to his height, not his weight. Any amount of weight does not change the lung size. Select any of the ventilatory mode, achieve a tidal volume of 6 ml per kg or 8 ml of kg depending upon the plateau pressure. The respiratory rate, you can go up to 35. This is from the ARDS net scale. And aim for saturation is 88 to 95. 90 is a very nice number, and PO2 of 55 to 80 millimeter mercury. Increase the beef with increasing FiO2 up to 24, they have gone, keeping the plateau pressure of less than 30 centimeter of water. The goal of pH is 7.3 to 7.45. This is what is our goal and what we set. The most important thing to know in ventilation, what is the predicted body weight of the patient. You have to remember an equation for male and female, it is different. For male, it is 50 plus 2.3 multiplied by height in inches above 5 feet. So you get a predicted. So basically, I am 5 foot 10 inches. My ideal body weight is 72 kg. And if I get ventilated with 6 ml per tidal volume, I do not exceed the tidal volume of 420 to 430 ml. So if your height is not 10 inches, 5 feet 10 inches, then you do not exceed 420 ml, no matter what is your weight. So open lung strategy or lung protection strategy. As I said, there are two kinds of knobs, 2 kinds of lungs, and only 4 knobs to remember. What are they? The knobs for tidal volume, the knobs for inspiratory flow rate, and the dial for respiratory rate, and FiO2 and P, they are considered them as one knob. The function is the same. So vital tidal volume, low tidal volume ventilation, 6 to 8 cc, so no more getting any patients getting ventilated with old 10 ml, 12 ml per kg body weight ventilation. 6 to 8 cc of ideal body weight, okay? Now what happens is, when lung get injured, it becomes a baby lung, a small lung. The availability of the lung tissues which is getting ventilated becomes small. This is what happening. 1/3 of lung is gone. So if it is tidal volume is 300, you should be ventilating with 200 ml. So 1/3 gone. What I'm trying to tell you that what are the 4 knobs functions is tidal volume is for lung protection. Tidal volume is not for ventilation. This tidal volume, if it is achieving a pressure of more than 30, then your lung is not protected. The only time you touch the tidal volume is when your lung is not protected. So it is always to come down. So tidal volume is never a ventilatory strategy. It's not a ventilation. Now, this is the dial where we usually forget inspiratory flow rate. Now, this is for the comfort of the patient. When we get sick, like suppose in a treadmill, we do for 5 minutes. You are sitting and breathing comfortably. Your flow rate is 6. The flow rate might be 30 or 25 liter per minute. But when you are sick, having fever or sepsis, then the flow rate goes up to 100. So one thing that, if the patient comes and struggling on the ventilator, system is calling, the patient is fighting with the ventilator, you come and see the patient, there is nothing wrong, you keep sedation or more anesthesia, go away. There might be a problem with the inspiratory flow rate. I don't know how much you are setting, but just have a look. If you increase the inspiratory flow rate, the patients get more air in less time. That's what they want at that time. So inspiratory flow rate is for comfort. Inspiratory flow rate in COPD or asthma, it has to be kept high. That is for a different reason. But the patient, when it's sick, and sepsis or lung injury type or ARDS type, they need increased inspiratory flow rate at the active phase of the disease. So respiratory rate, what is respiratory rate for and how much we need it? Now let's have a simple calculation. The upper value is prior to ventilation and the 120 ml, the lower value, is for patient after intubation. Normally we have a 60 ml per kg per minute of total ventilation. Now, when we get intubated and sick, the amount of requirement of the volume increases to double due to anatomical and physiological dead places and plus the circuit dead places. It just goes double. So if you give 120 ml per kg per minute, what happens is, suppose you are 70 kg, 120, so you need a minute ventilation of 8,400 ml. Suppose the tidal volume is 500 ml, you need around 17 breaths. I usually set all my ARDS patients to start with 18 breaths per minute. This is the reason why we start with. And after some time, you go and do an ABG or BGA and see where is your PCO2 is. And so according to that, you can go up and down with a ventilation strategy, which equals to respiratory rate. So respiratory rate equals to ventilation. Last dial is actually 2 in 1, PEEP and FiO2. They have one function, they do only increase in oxygenation. They have other functions also, but for discussion purposes, oxygenation means you increase your FiO2 and increase your PEEP. In ARDS net, they have a PEEP scale, low scale and high scale. In low scale, 0.3 they have given 8 PEEP, 0.4 they have gone 10 PEEP, 0.4 they have gone 14 PEEP. So gradually with each PEEP they have increased the oxygenation, they have increased the FiO2. Along with the FiO2 they have increased the PEEP to achieve a targeted 88 to 95% saturation. So PEEP and FiO2 is 1 knot. So what we have discussed till now, tidal volume is for lung protection, inspiratory flow rate is for patient comfort, respiratory rate is for ventilation equals to CO2 management, and FiO2 and PEEP is for oxygenation. So all kinds of theory are there, how much PEEP, where to give, lower inflection point, upper inflection point. So basically, if you follow the ARDS net PEEP scale, you will be somewhere there in between, okay? Here, if you follow the ARDS net scale, so you will be somewhere there in between the lower inflection point to the upper inflection point. You do not want to over-distend and you do not want to have atelectal trauma. So what if the plateau pressure is more than 30? Everybody recommends that plateau pressure should never be more than 30. Now if it is that, the only knob you change, what is that? Lung is not protected, so you will go down with your tidal volume. You will go down with your tidal volume again. So it goes down to keep the plateau pressure less than 30. So how do you measure the plateau pressure? So there is an inspiratory hold button in most of the ventilator. You can just press it, and I have a picture to show you. Remember, analgesia is more important than sedation in intubated, ventilated patient, those who are fresh, recently intubated. So basically, analgesia is a forgotten entity. It has to be taken care of more to get a better outcome from ventilation. So this is the inspiratory hold button. You just press it for 30 seconds, it gives a value that what is the plateau pressure, if it is not coming. So newer modes of ventilations, pressure control, it's not new, but APRB is, again, it is not new, 1970s, but gets popularized up to 2000 again. So this is the bi-level or bi-vent airway pressure release ventilation. SIMV with pressure control, SIMV volume control, pressure limited volume control, prone position, high frequency oscillatory ventilation, prone plus high frequency oscillatory. These combos are tried, vasodilators, nitric oxide, prostaglandins. ECMO ventilation, this looks promising. You put the patient on ECMO and give only 3 ml tidal volume, only 2 breaths per minute, so lung is not getting distended at all, and lower lung to carry out your carbon dioxide, even ECMO, oxygen with carbon dioxide. So depending upon what are these are some of those newer modes to look into it, but only mode that has a mortality benefit till now is volume control. That is the only randomized controlled studies by ARDS with a large number of patients that showed that lower tidal volume, 6 to 8 ml helps. Thank you very much. Hope you like it. So basically, to review, we have only 4 things and 2 kinds of lung. Obstructive type, injured type. Inshallah, we'll discuss the obstructive type sometime later on. But injured type has only 4 knobs to play. Tidal volume for lung protection, respiratory rate for ventilation, inspiratory flow rate for comfort, PEEP and FiO2 for oxygenation. Thank you very much. I'm really sorry that I could not make it. I miss you all. Hope you like my lecture. Thank you.